Kami menerapkan Self and Clean Hospital yang mengoperasikan rumah sakit secara modern dengan pelayanan klinis komprehensif, unggul, dan expert di bidangnya. Siloam Hospitals Kebon Jeruk telah mengikuti serangkaian standar kegawat daruratan dan tersertifikasi internasional. Siloam Heart Institute terdiri dari tim dokter spesialis jantung dan spesialis bedah jantung yang siap membantu pasien di bidang kardiologi dan dilengkapi fasilitas teknologi berstandar internasional. Kami memahami bahwa rasa sakit dapat membatasi aktivitas dan kualitas hidup seseorang. Pusat Unggulan Ortopedi menyediakan pelayanan diagnosa, perawatan, dan rehabilitasi untuk dewasa maupun anak-anak dengan gangguan tulang, sendi, atau jaringan ikat. Pelayanan urologi mencakup diagnosa dan perawatan gangguan pada ginjal, ureter, kandung kemih, prostat, dan organ reproduksi pria. Pusat Unggulan Saraf berfokus pada perawatan kontemporer otak, sumsum tulang belakang, dan gangguan saraf perifer melalui pelayanan pencegahan dan penyembuhan secara optimal. Spesialis penyakit dalam kami memiliki kualifikasi medis dalam mendiagnosa, memberikan perawatan, dan saran yang relevan untuk pencegahan. Pelayanan gastroenterologi kami menyediakan berbagai tes diagnostik dan perawatan untuk semua jenis gangguan dan kondisi pencernaan. Terdiri dari tim ahli yang berkomitmen untuk membuat perbedaan bagi kesehatan wanita di setiap tahap kehidupan. Dilengkapi layanan unggulan Neonatal Intensive Care Unit dan Family Center Care. Terima kasih atas kepercayaan Anda memilih Siloam Hospitals Kebon Jeruk. Kami bangga menjadi bagian dari kesehatan Anda dan keluarga. Kami selalu ada untuk Anda dan keluarga. Kami siap melayani dengan segenap hati. Siloam Hospitals Kebon Jeruk didirikan pada tahun 1991 dan menjadi rumah sakit yang pertama kali diakuisisi oleh Siloam Hospital Group. Secara strategis terletak di Jakarta Barat dan mendapatkan akreditasi baik nasional ataupun internasional. Kami menerapkan Safe and Clean Hospital yang mengoperasikan rumah sakit secara modern dengan pelayanan klinis komprehensif, unggul, dan expert di bidangnya. Siloam Hospitals Kebon Jeruk telah mengikuti serangkaian standar kegawat daruratan dan tersertifikasi internasional. Siloam Heart Institute terdiri dari tim dokter spesialis jantung dan spesialis bedah jantung yang siap membantu pasien di bidang kardiologi dan dilengkapi fasilitas teknologi berstandar internasional. Kami memahami bahwa rasa sakit dapat membatasi aktivitas dan kualitas hidup seseorang. Pusat Unggulan Ortopedi menyediakan pelayanan diagnosa, perawatan, dan rehabilitasi untuk dewasa maupun anak-anak dengan gangguan tulang, sendi, atau jaringan ikat. Pelayanan urologi mencakup diagnosa dan perawatan gangguan pada ginjal, ureter, kandung kemih, prostat, dan organ reproduksi pria. Pusat Unggulan Saraf berfokus pada perawatan kontemporer otak, sumsum tulang belakang, dan gangguan saraf perifer melalui pelayanan pencegahan dan penyembuhan secara optimal. Spesialis penyakit dalam kami memiliki kualifikasi medis dalam mendiagnosa, memberikan perawatan, dan saran yang relevan untuk pencegahan. Pelayanan gastroenterologi kami menyediakan berbagai tes diagnostik dan perawatan untuk semua jenis gangguan dan kondisi pencernaan. Terdiri dari tim ahli yang berkomitmen untuk membuat perbedaan bagi kesehatan wanita di setiap tahap kehidupan. Dilengkapi layanan unggulan Neonatal Intensive Care Unit dan Family Center Care. Terima kasih atas kepercayaan Anda memilih Siloam Hospitals Kebon Jeruk. Kami bangga menjadi bagian dari kesehatan Anda dan keluarga. Kami selalu ada untuk Anda dan keluarga. Kami siap melayani dengan segenap hati.
Yuk kita mulai ya, Dokter Firman.
Ya, dokter.
Ya, selamat pagi teman-teman semua. Selamat pagi Dokter Antono, selamat pagi Dokter Cecilia Padang. Selamat pagi juga untuk Dokter Pipin yang pagi ini sudah meluangkan waktunya untuk sharing tentang khususnya tentang aritmia pada kondisi kardiovaskular. Nah, pada pagi ini kita akan supaya tidak menunda-nunda lagi, segera kita buka. Untuk yang pertama, kita persilahkan untuk Dokter Cecilia Padang untuk menyampaikan sematerinya, Dokter.
Ya, ini kok ada. Sebentar. Terima kasih. Apakah suara saya sudah terdengar?
Sudah, Dokter.
Sudah ya? Kok ininya nggak bisa dibuka? Ya, maaf. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Salam sehat bagi kita semua. Selamat pagi teman-teman semuanya. Yang terhormat Direktur Rumah Sakit Siloam Kebon Jeruk. Yang terhormat pembicara kita pada hari ini, Dokter Antono Sutandar, SpJP Konsultan. Kemudian Dokter Pipin Kojodjojo, Cardiologist dari MONI Hospital Singapura. Welcome to Dokter Pipin. Dan moderator kita Dr. Firman Teja Sukmana, SpJP. Serta teman-teman sejawat sekalian yang ikut bergabung pada pagi hari ini ya. Masih pagi tapi rupanya sudah pada rajin semuanya untuk mengikuti acara webinar kita pada hari ini. Pertama-tama saya mengucapkan terima kasih kepada Siloam Kebon Jeruk yang terus-menerus mengadakan webinar untuk menambah pengetahuan kita tentang hal-hal yang masih baru yang sangat-sangat kita perlukan ya. Dan pada hari ini kita ada pembicara-pembicara yang luar biasa. Saya berharap acara pada pagi hari ini dapat menambah wawasan kita dan terutama untuk pasien-pasien kita pada umumnya. Teman-teman sekalian yang saya cintai, dari Ikatan Dokter Indonesia, saya ingatkan bahwa kita sekarang tidak menggunakan lagi Smart ID online, tetapi kita menggunakan webnya idonline.org. Jadi untuk memperbarui keanggotaan kita, apabila sudah habis 5 tahun, maka kita menggunakan idonline.org. Bagi yang belum menerima KTA, bisa dibantu dengan hotline PBID, mohon dicatat 0812 555-333-65. Namun apabila ada halangan dengan KTA ID ini, karena kita tahu bahwa KTA ini kita perlukan sekarang untuk ganjil genap ya. Jadi kalau ada halangan bisa menghubungi sekretariat, nanti kita akan bantu untuk mencetak. Selanjutnya mungkin kita akan mencetak sendiri untuk kartu keanggotaan daripada ID. Baik, teman-teman sekalian, pada kesempatan ini saya hanya mengingatkan kembali bahwa kita sebagai dokter hendaknya dalam menjalankan profesi kita sehari-hari kita tetap berpegang teguh pada kode etik kedokteran dan sumpah dokter. Saya berterima kasih karena selama kepengurusan saya di Jakarta Barat tidak ada masalah-masalah antar teman sejawat. Terima kasih teman-teman sekalian yang saya cintai. Terima kasih juga ke atas bantuan teman-teman selama kita dalam masa pandemi, di mana kita sudah membantu untuk proses vaksinasi dan booster, dan beberapa klinik juga ada klinik yang sudah mendapatkan rekor muri karena pencapaian vaksinasi yang lebih dari 120%. Terima kasih kepada teman-teman sekalian yang saya cintai. Pada pagi hari ini saya kira saya tidak berpanjang lebar, hanya saya ingatkan kembali kita juga harus berhati-hati dengan telemedicine. Walaupun kita ada fatwa dari MKEK bahwa kita boleh menjalankan telemedicine di era pandemi ini, yang selanjutnya nanti akan ditinjau kembali, tetapi kita harus berhati-hati bahwa telemedicine ini harus dilakukan di Fasiankes dan kita harus mengisi medical record dengan lengkap ya. untuk menghindari hal-hal yang tidak kita inginkan. Apabila ada masalah-masalah atau hal-hal yang kurang berkenan dengan kepengurusan kami, mohon dapat langsung ke handphone saya di 0816 952713. Nanti kita akan respon. Baik, teman-teman sekalian, saya sampaikan juga bahwa sampai hari ini saya berterima kasih karena tidak ada satupun anggota yang mengundurkan diri dari keanggotaan IBI, dan sampai pada hari ini IBI adalah satu-satunya organisasi profesi yang di bawah undang-undang yang mempunyai wewenang untuk memberikan rekomendasi izin praktek. Ya, untuk itu mari kita tetap solid dan tetap bersatu di dalam rumah besar kita, Ikatan Dokter Indonesia. Baik, untuk tidak membuang waktu, maka acara pada hari ini, webinar ARRHYTHMIA webinar Updated Therapy in Advance Electrophysiology, saya buka dengan resmi. Terima kasih kepada MC kita pada hari ini, dan saya berharap acara pada pagi hari ini akan bertambah sukses dan kerjasama yang baik dengan Siloam Kebon Jeruk akan berlanjut terus di masa-masa mendatang. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Oke. Terima kasih banyak Dr. Cecilia Padang selaku Ketua ID Cabang Jakarta Barat telah membuka acara ini di pagi hari ini. Baik, saya bacakan singkat ini rundown acara kita untuk pagi ini. Setelah pembukaan oleh Dr. Cecilia Padang, kita akan mendengarkan presentasi dari yang pertama oleh Dr. Antono Sutandar, Spesialis Jantung dan Pembuluh Darah mengenai Arrhythmia Management and Prevalence. Dr. Antono akan menyampaikan sebuah kasus yang menarik buat kita untuk simak bersama dan pelajari bersama. Dan kemudian setelah Dr. Antono selesai presentasi, akan dilanjutkan presentasi oleh Dr. Pipin Kojodjojo dari MANI Singapura. Beliau akan menyampaikan presentasi mengenai Advance Electrophysiology. Ya, mudah-mudahan kita bisa mendapatkan materi dan ilmu yang bisa kita gunakan dalam praktek kita sehari-hari. Selanjutnya, sekarang saya serahkan kepada Dr. Antono. Silakan untuk memulai presentasinya, Dok.
Terima kasih buat hadirin sekalian. Terima kasih juga buat Dr. Pipin yang telah meluangkan waktunya untuk ikut berpartisipasi di dalam webinar ini. Saya sebenarnya bangga juga di Singapura ini sudah banyak dokter yang either orang tuanya atau yang lahir di Indonesia ya. Yang pertama kalau nggak salah itu Dr. Lim Tai Tien yang pertama, itu sebelum saya di NUH. Yang kedua di NUH itu saya, terus abis itu ada 3 dokter Indonesia lagi yang di NUH. Siapa ya, Dokter Pipin, ada satu yang di bagian struktural, mungkin Dokter Pipin ntar bisa share juga sama dokter yang di monitor. Ada satu dokter yang juga sudah praktek juga di Novena. Mungkin Dokter Pipin bisa share juga mengenai 3 dokter yang sekarang aktif berpraktek di Singapura. Ya. Ya, ini kita mau presentasi kasus ya yang menarik, dan diharapkan ini bentuknya lebih dalam bentuk interaksi, dan mungkin inputnya Dr. Pipin ini juga sangat penting. Ya. Yuk kita mulai aja. Jadi kita mau presentasi ini kasus laki-laki berusia 44 tahun yang datang ke emergency room dengan berdebar-debar dan pernah pre-syncope, dan pada saat dia masuk ke dia syncope. Ya. So this is a 44-year-old male who was admitted for palpitation and had a history of pre-syncope twice at least by history, and was admitted after a syncopal episode. This was his resting ECG some time ago before admission. Dr. Pipin, would you like to comment on the ECG? Halo, Dokter Pipin udah ada?
Belum join.
Oh, so Dokter Pipin belum ada di tempat ya? Coba Dokter Renaud ada komentar nggak ya mengenai EKG ini? Dokter Firman, gimana Dokter Firman?
Baik dokter. Jadi kalau kita lihat di sini ini dari EKG ini kita bisa lihat iramanya masih dalam sinus rhythm, tapi yang bisa kita lihat ada kelainan adalah di mana ada T inversion dari mulai V1 sampai V4 dan di lead inferiornya di 3 dan AVF-nya. Pada saat ini sih tidak ada tanda-tanda yang terlalu signifikan ya dok, dan ada sedikit elevasi di 1 dan AVL-nya dok.
Ya. Saya rasa yang penting ya untuk dokter jantung itu menyadari bahwa kadang-kadang ya T-wave inversion yang terutama lebih prominent di V1, V2, V3 ini kadang-kadang pertanda awal bahwa RV ini bermasalah. Bahkan kadang-kadang pada saat orang acute pulmonary embolism pun kadang-kadang tandanya kadang-kadang cuma sinus tachycardia dengan T-wave inversion terutama di V1 sampai V3 ya. Jadi walaupun di sini nggak ada tanda-tanda lain, selalu ingat bahwa T-wave inversion di V1 sampai V4 kadang-kadang bisa merupakan pertanda awal bahwa ada masalah. Nah, yang lain-lainnya kita seringkali sebut nih early repolarization ya, bisa lihat di V5, V6, di Cardiologist di lead 1 itu juga tanda-tanda yang seringkali kita sebut early repolarization. Yang juga agak menarik di pasien ini sebenarnya QT intervalnya ini cukup panjang. Entah kenapa QT interval ini seringkali memanjang pada saat juga ada perubahan T-wave inversion ya. Ya ini aja dari EKG-nya. Waktu dia datang ke emergency room ini ECG-nya. Ya, next. Ya. Jadi ini kita bisa lihat ya. Kita juga bisa lihat dari V1 sampai V6 semuanya nih QS pattern ya. Seringkali sesuatu yang dari V1 sampai V6 ini semuanya QS pattern itu berasal, itu artinya dia seringkali berasal dari daerah apex ya. Ya kalau semuanya positif ya dia dari daerah basal, tapi kalau semuanya negatif cenderung berarti dia dari daerah apex. Ini yang menarik. Dan semua yang QRS-nya semuanya berasal dari daerah apex, ya itu hampir diagnostik bahwa ini ventricular tachycardia, bahwa ini berasal dari ventricle. Ya. Oke, Dokter Pipin sudah join atau belum ya?
Harusnya 2 menit lagi dok, beliau join.
Oke, next slide.
Eko ya.
Jadi kita mau presentasi echo-nya ya. Coba kasih echo yang pertama sama yang
Ini
ketiga.
yang pertama.
Ini echo yang pertama, bisa lihat. Ini kok di sini nggak ada?
Di sini dok.
Nggak di sini?
Kita nanti ya baik.
Ya, oke. Ya ini kita lihat dari awal ya. Ya, ini gimana yang ada yang lain yang selain Dokter Firman? Ada yang Dr. Titus, gimana Dr. Titus bisa komentar mengenai ekonya? Halo Dr. Titus. Halo Dr. Elisa ada yang ada.
Hai dok, tapi masih nyetir ini dok ya, jadi saya nggak bisa terlalu lihat. Tapi yang pasti ini kan LV functionnya bagus pesannya. Kalau tadi saya lihat yang dari chambernya kayaknya RV-nya agak besar ya dok ya.
Iya,
tapi,
di sini
ya,
juga kelihatan artinya besar.
Iya.
Apalagi yang menarik? Ternyata papillary muscle-nya bisa lihat di sini.
Iya, papillary muscle-nya agak besar dan
prominent ya, dan dia hiperreflektif. Bisa lihat ya, lebih putih daripada di belakangnya dan di depannya. Ya, dan jauh lebih besar papillary muscle ini daripada papillary muscle yang di bawah. Ya. Dan di sini juga bisa lihat ya, RV-nya kelihatan membesar. Biasanya RV ini nggak kelihatan sebesar ini di parasternal short. Nah, ini apex-nya nih. Apex-nya ini kelihatan agak hipokinetik pada saat dia masuk ya, tapi ya subsequently dia ada perbaikan. Ini apa yang kita lihat? Kita bisa lihat RVOT-nya ini membesar ya. Dan kalau biasanya RVOT ini hampir sampai kolaps pada sebagian besar orang, ini kelihatan RV-nya ini tetap membesar pada saat dia diastolik. Semuanya ini menandakan bahwa ini ada masalah dengan jantung kanan. Dan kita juga bisa lihat ke TR-nya nggak terlalu. Ya. Salah satu yang menarik lagi ini bisa lihat moderator band. Moderator band-nya juga agak hiperreflektif ya. Jadi tanda-tanda moderator band hiperreflektif dan tanda-tanda bahwa papillary muscle-nya juga hiperreflektif. Ini biasanya menandakan ada masalah lain. Di sini bisa kelihatan ya, nggak jelas tapi ntar ada gambar yang lebih jelas. Di sini bisa kelihatan bahwa RV-nya membesar. Ya. Lagi-lagi ini moderator band-nya kelihatan tuh agak hiperreflektif. Jadi hati-hati kalau lihat papillary muscle dan moderator band yang hyperreflektif. Ya. Nah, ini TR-nya dan TR-nya nggak terlalu parah. Ya, menandakan bahwa ada RV dilatation tapi tidak ada pulmonary hipertensi. Ya. Ya, saya lihat ada. Oh, Dr. Pipin sudah join ya. Thank you ya Dr. Pipin untuk ikut berpartisipasi.
Terima kasih untuk keundangan.
So, I'll just review with you. We'll just go back and show you the resting ECG. If you can make a comment on the resting ECG and this is the ECG on clinical presentation.
Okay.
So I just mentioned it's a QS pattern across the board from V1 to V6, suggestive that it's a ventricular in origin and it's likely coming from the apical part. And this is his resting ECG.
Yeah.
You have any comments about the ECG?
No, I mean, I think the resting ECG looks, so there's a non-specific T-wave inversion in the chest leads, non-specific ST elevation in lead 1, lateral leads, but that aside, it looks pretty normal to me. Yeah. The QTC is, on the machine is slightly elevated, prolonged for male, I think.
Yeah.
So it's a little bit long for a guy. The only thing with the broad complex tachycardia is that, you know, it probably is VT, but it's hard to tell when it's so fast. I mean, you know, I've seen flutter with 1-to-1 look like that.
Yeah.
So it's just a
I
regular.
think it says that the QS in P1 to P6, it looks like
Yeah,
the
agree.
QS pattern is very suggestive. It's coming from the RV index.
Yeah,
There's
agree.
almost nothing. But I agree. All these rules about the right QRS and all that, you can still be fooled with whatever rule you use.
Yeah, agree. Yeah.
I just showed the echo. So yang echo yang ketiga tuh.
Iya dok. Ini langsung saya kontak.
Yeah, so the first echo was there was evidence that the RV was dilated.
Yeah.
And then let me just show you the. So we're just going to focus more on the LV looks okay. Initially, the LV apex look a little bit hypokinetic, but this is sometime after he recovered from his VT, and he got shocked for his VT to restore sinus rhythm. Yeah. So this is you can see here that the RV is dilated. On some of the views, you can see that the papillary muscle is also hyperreflective. You can see here the massive dilatation, the prominent trabeculation, and on some of the views, we can also see that the prominent moderator band and the hyperreflective moderator band.
Yeah.
Let me just show you. Maybe there's some nicer pictures of the. Okay, so this is the. You can see here the moderator band coming in and out, and it looks quite hyper-reflective. But we didn't focus on the moderator band this study. And you can see the prominent trabeculation in this dilated RV. Actually, over here, you can see here also you can see that the trabeculation and the moderator band looks more hyper-reflective. Yeah. Here you can also see the hyper-reflective papillary muscle over here. Here you can see you have the apex is very prominent, and there's an impression that there's an aneurysm over here. You can just focus on this. Yeah, here I think you can see it better. You see?
Yeah.
So actually, let me ask you several things now. Do you think that based on the ECG, the VT, and the echo, that we have enough evidence to suggest that there is an RV cardiomyopathy going on, then and that it's ARVD, or do you require further evaluation?
I guess so I assume there's no family history, right? There's no family history of
There's
sudden.
no family history of sudden cardiac arrest.
I mean, based on the ECG changes and the echo changes and the VT, he already fulfills diagnostic criteria for ARVC, right?
Yeah.
Because VT, right-sided chest leak changes, features of aneurysm and RV dysfunction on echo. So he already meets the criteria.
Yeah.
I guess the only thing is that the left ventricular function looks down to me too, which is quite unusual in early ARVC, but he may be having quite late stages of ARVC. I guess a cardiac MRI full as a confirmation, but you already meet the diagnostic criteria for ARVC.
Okay. So what do you think about the clinical presentation? The most common the most frequent initial clinical presentation of these patients with ARVD is almost never sudden cardiac arrest. That's my impression. What's your impression? It's mostly palpitation or pre-syncope, and sometimes a syncope, and rarely do they present initially with right ventricular heart failure. What's your experience?
Yeah, I agree. I rarely see failure or even right heart failure from them. It's usually VT that they come with. Although having said that, I have seen a few cases of sudden death. So a lot of them, they have a history of sudden death in the family. But I don't know whether it's because they ignored their palpitations and they didn't see a doctor for palpitations and therefore they end up with sudden death. But it's usually arrhythmic, the presentation. So.
Yeah, that's my impression too, that mostly you'll start with palpitation, pre-syncope, syncope.
Yeah.
RV failure is quite late in the clinical presentation. And usually it's very rare that unless it's ignored, I guess, that they present with sudden cardiac arrest. Now, the other interesting about the ARVC is that there has been report of RV thrombus being quite frequently seen in these patients. What do you feel about this?
I think they're usually quite hard to see on the echo. You need to look at it on the MRI to see it. I don't really know what to. I've seen a few cases. I have given anticoagulation, but I'm not sure it's any evidence based for doing. And also, that very difficult to image. You sometimes see this aneurysms, trabeculations, and then some look like trabeculations, some look like clots. So I'm also not sure. Very rarely ever rescan them again, because usually after a while they have an ICD inside. So we end up treating them, and then we echo for 6 months, and then we echo them. If it looks okay, we stop anticoagulation.
Yeah. Do you put the ICD in after you have confirmed there's no RV thrombus, or because I remember when I was at NUH and RV thrombus was not the literature didn't say much about RV thrombus. Actually, I slapped in an ICD in without knowing that. But lately, there has been report that RV thrombus can be seen up to 1/3 of these patients. And I was just wondering whether you always need to do an MRI first just to make sure about the RV thrombus, unless you can see it on echo.
No, so I mean if there's RV thrombus, the only thing that changes my practice is that I don't do a defibrillation threshold. I don't induce ZF on them. So that I don't do. The MRI I tend to do because once the device goes in, you can't have an MRI anymore. And like your patient here, they're all relatively young. So I do the MRI just because it's probably the last chance he can do a cardiac MRI.
Right.
So that's the reason for doing it, but not really to look for the thrombus.
Okay. So basically, if you didn't have an MRI, would you have done an EP study, and would you have slapped in an ICD, or would you have just slapped in an ICD?
I think often I do I don't tend to do an EP study. I'm not sure about the diagnosis. Let's say if the echo came back as normal, I would certainly do a MRI and an EP study. But in your case, the echo is clearly abnormal. Even the left ventricle is a little bit down. The ECG is abnormal. He's got documented VT. That for me is enough to do a ICD. And then at the time of the implant, if it doesn't have any visible thrombus, I would do an EP study through the ICD lead to induce the arrhythmia. Right?
Okay.
So that's
so you would do an RV-gram on your before you slap in your ICD?
No.
To look for an RV thrombus, or what?
I try not to look for trouble.
So I think that's the issue. Anyway, in the past, we used to put ICD in without knowing that there is an RV thrombus or not.
Yeah.
Now, that's just my take on the issue. But now knowing that it's quite frequent, I just wonder whether we need to look for RV thrombus every time before we put an ICD in. And well, at least you have reasons to put the patient on NOAC.
Yeah.
They have an RV thrombus. And I just wonder what's the literature. Once you put on NOAC, will they all dissolve? And but do they need long-term NOAC once you have an RV thrombus? Or
Don't know. I mean, even before this issue was raised, we never used to anticoagulate these patients. For some reason, we don't see a lot of them with AF compared to like hypertrophic cardiomyopathy. So I can think of 1 or 2 ARVC patients who has AF at the same time. So often the NOACs are all stopped. And the other point about your RV angiogram is that I have seen so few RV angiograms in Korea. I'm not sure how to interpret them. And so I think when I was starting as a trainee, I did some LV angiograms during CAF, but RV angiograms is, for me, probably quite hard to find clot on them.
actually, it's very interesting. That's the advantage of being an older cardiologist because, well, obviously I have more white hair. But you know what? Well, I was at NUH, I would actually do an RV-gram on all of them, before we had a cardiac MRI and all that. The things that we would look for is actually do it in 2 views, do one in RAO and do one in LAO, cranial. And we would look actually for the RV apex in particular and the outflow tract, because contractility would often be impaired in those 2 areas, except for them being dilated. And sometimes we would see RV aneurysms. Actually, I have some examples. They're probably still in NU8 in the computer system there. But some nice examples of those things. But yes, I have to admit that in 2001 until 2005, while I was at NU8, these patients would get a routine RV-gram.
I'm going to look for them.
Yeah, but I'm not sure whether they're still there. They're probably, it's already 20 years ago. So, but that's just one take. But very interesting. We did an EP study. Can you show the EP study?
Yeah.
And the EP study actually also induced ventricular tachycardia of a different morphology. Yeah, so this is the EP study. Next, you can see it's a left bundle branch block. Next, this is the VT that we induce. You see, it's a different morphology.
Yeah, but still right-sided, right.
Still right-sided, but at least there's some positivity in V4 to V6. Well, I think the previous ECG was a pretty QS pattern in V1 to V6. So we were quite confident based on everything.
Yeah.
Actually, we also did an RV-gram just because and we can see the RV dilatation and those things that I mentioned, but unfortunately the RV-gram got lost. So I cannot show you. The patient still has a copy, but somehow our cath lab forgot to take pictures. The angiogram was basically normal. We just did it for completion's sake because he's 44 years old. Yeah. And we also did an MRI. Yeah, these are the MRI pictures. You can see here that there's an RV thrombus.
Yeah.
Over here. So it's different. They can see it on both views, and you can also see that there's an impression of aneurysms over here. Next. Yeah, here you can see the aneurysm very clearly.
And clearly the RV is much bigger than the LV.
Clearly, the RV is much bigger than the RV. So actually, I agree. Although we didn't need it, but I found the MRI useful in detecting the RV thrombus. And I just wonder if I just slap an ICD in and put it in the RV apex, would I have the slots the RV thrombus? You think?
I don't know, not sure. I think that you end up with very low R waves, which is always the problem with putting the ICD leads in this. You can't find those.
So would you just slap it in the septum?
Yeah.
Yeah. Okay. So you wouldn't even your first choice would not even to bother for the RPA, but you would just intentionally go for the septum in these patients.
I think looking at your MRI, you can see that the apex is almost gone. I don't really see much myocardium in the apex. There's some in the basal lateral wall. There's the septum looks spared. So I would probably go for a sort of very septal lead position for the ICD, I think.
Or would you do that by default, or would you even try if your lead falls in the RP apex? Would you?
Yeah, I can try. I can try. Yeah, but I typically find very low R rates in these.
Yeah, I agree.
You get like 1, 2, or 3, and then you're worried that it will fall the next day. So I end up not leaving them there.
Okay, so by default, you would immediately go for the RV septum, knowing that the patient had ARVD.
Yeah, I mean, usually if it ends up there, I try, but usually I think most of my leads end up in a septal position, a septal position. Yeah.
Okay, so this is the MRI report now. So it's in keeping with ARVC. We requested the evaluation for ARVC.
Yeah.
I think they did some late gadolinium enhancement, and they said the RV free wall and the apical RV myocardium, there was some enhancement. Although I'm not sure whether they said early or late enhancement, but I guess even if you have late enhancements, it's all consistent.
Yeah, but the aneurysms are more diagnostic, I think, for me.
Yeah, and they mentioned the organized thrombus.
Yeah.
They mentioned the aneurysm also. So, what's your take? The patient actually has still refused an ICD, lah.
I mean, as you know, there are some people doing ARVC ablations as DT ablations as I guess not alternative, but for patients who decline ICD to reduce their risk of arrhythmia. I don't think there's any robust data to it, and I think ICD should still be the first line treatment.
Yeah.
But there are certainly some people doing. Does he have any more palpitations? No more BT.
Well, he has had some palpitations, but he hasn't returned. It has been, I think, 3 months since his last clinic visit.
Right.
And at that time, he still refused. He wasn't sure about the ICD yet. So he's still walking around now, and he's hasn't died yet. So so maybe he'll show up at your clinic. And
yeah, thank you. Happy to see him.
Yeah, I told him you can get a second opinion. I told him, but I think we did our part. I said, and I said the bulk of evidence is looks like you have ARVD. I told him also to get some his children screened for it.
Yeah.
And told him that the clinical presentation is usually palpitation, syncope.
Yeah.
And if he's very unlucky, he may die suddenly, but usually the progression would be palpitation, syncope. And at the very late stage, they would be having a right heart failure. And actually, it's quite lucky if he dies suddenly.
Not sure about that, but I mean, there are now a lot of the DNA companies that makes the genotyping for the cancer. They have these panels for ARVC already. It's not very expensive. In Singapore, it's about $150 to get a panel done. So you test for your plakoglobin and your desmosomal mutations, and I suspect that's probably the fastest way to screen his children.
Yeah, one of the genetic abnormality that they find, if I remember correctly, is also frequently seen with this polymorphic VT, the exercise-induced polymorphic.
The CPVT, the catecholamic polymorphic VT. Yeah.
Yeah, but has there been cases where the father presents with ARVD and the son presents with a different with the VT, or are they actually two different kind of mutation?
I mean, it's possible. The ARVC also has overlap with some forms of hypertrophic cardiomyopathy. So you do. I've got one family I know. The father is positive. The son is positive, but the son at 50 still has no phenotype, hasn't expressed the gene yet. So I don't know why. So the son genetically is predisposed to having ARVC, but his echo is completely normal. Okay. So I think expression is one of the funny things, is that you can have the gene for it, but you may not use it. So if you don't use it, then there's nothing to see. So
okay. So that's the end of my presentation. Thank you, Dr. Pipin, for
thank you
for the very helpful interaction and for your take on the case. I told the audience actually that I'm very proud that at this moment, I think at least I know 5 doctors in Singapore that have some connection with Indonesia, whether the parents or whether they were born there. And I mentioned they were all from NUH. Do you know that, Dr. Pipin?
Really?
Yeah, the first one was Dr. Lim Tai Tian. Do you know that?
Yes.
Do you know him?
I know him, but what's his connection to NUH?
Well, he was also at NUH before he moved to SGH.
Oh, I didn't know that. I thought he was always at SGH.
No, he was first at NUH.
Oh.
But I think he could. He went to private practice and then took up a position also at SGH.
I see. I didn't know that.
So that's the first Indonesian that I know, and I guess I was the second Indonesian. And then I think after me there were 3 more, right? Can you mention their names?
So
my brain is a little. I'm getting old, but I.
There's myself. There's Ivan Dito Kojodjojo.
Ivan Dito, yeah.
Yes. And then Nicholas Wanahita is vaguely NUH but he was really more in Teng Fong.
Where was he based? I forgot.
He was based at the Alexandra Hospital, and then went to Teng Fong for a while, and then now he's gone private also. He's an internist. So Nicholas, he was trained in Columbia, so as in New York City, Columbia University. So that system. And then I think that's it. Is there anyone else?
Yeah, so that's 5, right?
5, yeah.
So
William Cristanto, but he doesn't speak any Indonesian at all. In fact, he's fully Singaporean. So it just.
Oh yeah, there's one. Yeah. I heard there's one more. Yeah.
Yeah, but he's really not. He really has no link to Indonesia.
Maybe his parents.
Only his parents. Yeah.
Yeah. So that's some link. Were you born in Indonesia or were you born in Singapore?
No, I'm born in Tokyo.
You're born in Tokyo. Good. Okay, well, I'll give you the floor. I'll give you the mic to start speaking on your topic. And if you want to say some words about, I see AHVC. Maybe you want to promote your group. So a little bit about our group. Our group consists of 8 cardiologists.
Yeah.
So we have 2 interventionalists. There's another electrophysiologist in our group. I'm not sure what I am anymore. I'm probably just a general cardiologist by now.
You're the boss.
Well, I'm the oldest. I'm the one with the most white hair. That's the only thing I can say. And then we have someone, an expert in imaging, Dr. Natanya, who's an expert in echo and cardiac CT scans, and also interested in MRI. Then we have some Dr. Elisa, who's more towards the vascular side, who's doing the PVDs. Oh yeah, we're also doing a tunneling dialysis catheter tunneling, PICC, which is all done by Dr. Elisa, working together with an interventional radiologist, so to do the cases both together.
Yeah.
And we have, hopefully, I'm trying to send Dr. Firman for EP training. So maybe if you can help, and I haven't contacted Sui Chong yet. Is he still head of EP?
Yes. She just still head. We would love to have them come over. Yes.
Yeah. Maybe I'll. You're still at NUH too?
I'm a visiting consultant there, so I help them do cases, but I don't run clinics anymore.
Yeah. I used to do that too, you know, before Lasak finished his EP training.
Yeah.
And then they kicked me out after you had enough people, after Sui Chong and Rasak were there.
But certainly come over. I mean, APHRS is in Singapore in a few months' time, so come over. You can meet everyone.
Yeah, when is HRS?
November this year, APHRS. We're in Suntec City. There are 3,000 people coming for a face-to-face EP meeting.
Yeah. So Firman, just make sure you know that we'll be coming to Singapore and chat with these guys.
Yes.
And
you can choose which center you want to work at. There's 2 EP centers in Singapore you can train at. You see which one you like.
Okay. Well, the floor is yours.
Okay, thank you. Okay. So Sutandar, thank you very much for the invitation. I was asked to talk about anything in EP, so I chose something that I've been spending a lot of time on, which is conduction system pacing. So we'll just spend the next 15 minutes talking about conduction system pacing. So okay, so I use fast forward. So we all familiar with pacemakers. You know, we've been using them to treat bradycardia for now. Can you see my slides? You can, right?
Yeah.
Okay. And so essentially, you know, we've gone a long way. This is the first guy who got a pacemaker. He's basically stuck in hospital. And then they made the first portable pacemaker looked a little bit like this. And the shape is like this because the engineer who made it didn't have a box. So he went to find shoe polish and he poured the resin into shoe polish. So this box created the first pacemaker. And now, you know, they are all very small and we're all familiar with them, usually dual chamber, small scar, battery is good, more than 10 years, and more than 1 million implants a year. However, there's something sad when we put a pacemaker in, and that's that we completely abandon the His-Purkinje system when the pacemaker goes in. Because I think most of us realize that, you know, the His-Purkinje system is actually a masterpiece. You know, you have this dense network that allows electrical signal to reach every single cell of the heart within 90 milliseconds. So that results in our narrow QRS. So in fact, what we are doing when we put an RV lead in is that we are abandoning this whole system and say, well, we just pace from one point. Which clearly is not going to give you the same effect as pacing from or using the natural network. So over the last few years, the idea of physiological pacing or conduction system pacing has started. And there are really just two fundamental principles that people need to know. One is that the Purkinje system, which starts at the AV node, is not random. Is that there is a fixed pattern how things come out, So it's like railway. So when you are on this track here coming out of the AV node, you know that you're going to become the left bundle. And then if you're on this track here, you know that it's going to become the right bundle. So there's no crisscrossing of wires and things. Everything is actually very, very organized. The second thing that people always thought, in fact, I always thought that, was that when you have bundle branch block, let's say left bundle branch block, people thought that all the railway beyond the side of block was all destroyed and there was no railway left. But actually, we know that's actually not true. What we have when we have left bundle branch block is that you have a small gap in the left bundle system. And actually, once you get past the gap, the rest of the track is actually normal, right? So all you have is a small little gap that's causing the bundle branch block. So it doesn't really make sense that we have to abandon the whole railway network just because there's a small gap in one area of the track. Okay. So people came up with this idea of saying, instead of putting our RV lead at the apex, which is where we've been doing it for many, many years, why don't we try and capture the bundle branch or capture the conduction system just after the gap in the track, right? So you just go beyond it and you paste distal to it, and then you make use of the whole network again. And in some ways, it provides a very clean solution. So if you see, these are the reasons why in the first column we do pacing for. We pace some patients with narrow QRS. These are typically 6 sinus patients. Their QRS is narrow. We pace patients with bundle branch block, especially for CRT. For heart failure. We also pace patients with long PR intervals. So this is typically 2nd-degree block or even complete heart block. So this is the 3 pacing indications. Now, if you look at our current pacing solutions, if you do so for a patient who has narrow QRS, of course you can lengthen the AV delay and not pace them. But if you end up pacing them either with RV pacing or bivent pacing, the QRS is always broad. Okay, the QRS is narrower in biventricular pacing, but it's not normal, it's not narrow. And that's the same whether for the left bundle patients and for the narrow QRS patients. Now, when we do conduction system pacing, because we are capturing the same Purkinje system that gives rise to the narrow QRS, you end up with basically the same ECG. You end up with a narrow QRS, no matter which patient group you apply this to. And so in some ways, actually, it's a very, very elegant solution to fixing conduction system problems. So I'm going to demonstrate that with an ECG. And so this is a patient who starts off with having left bundle branch block. He has heart failure. Okay, so this is a way of doing CRT. So you can see here, this is the unpaced ECG. The QRS is broad. This is V6. And then what you do is that once you can capture distal to the block, so here's the AV node, pretend that this is the site of the left bundle branch block, and you pace at 2 volts, okay? Now at 2 volts, what you're going to do is that you're going to capture the right bundle, you're going to capture the left bundle, and you're going to capture the muscle around it. So this is what we call non-selective His bundle capture. You can see the ECG is nice and narrow. Because you are capturing a little bit of muscle, there's a little bit of a delta wave, which looks what you will see in patients with WPW. Now you lower the output by 0.5, okay, so to 1.5, and now you don't capture the muscle anymore. You just capture the left and right bundle. And so this is what we call selective His bundle capture, and it corrects, most importantly, it corrects the left bundle branch block that you see. And so now you have a narrow QRS, okay, which this guy used to have before his left bundle branch block. Now, if you lower the output further, this is to 1 volt, right? You then capture the His bundle, but the capture doesn't capture the fibers after or distal to the block. And so you end up replicating the same ECG as the patient before pacing. Okay, so you captured the His bundle above the side of block. So you end up with just left bundle branch block. You're still pacing. Okay, so therefore, by varying the output, you can capture different parts of the conduction system, and that allows you to correct or not correct the ECG. And so what a CRT will look like when you use something like this would be like this. You're familiar with the RA and RV lead, but the third lead, the left bundle lead, the left ventricular lead becomes something that is stuck in the septum. So this is a His bundle system. We also have realized over the last few years that about 10% of patients who you give a pacemaker to who have a normal EF to start with will develop heart failure over time during follow-up. And this is something called pacing-induced cardiomyopathy. And so here is 60 patients. At baseline, they all had a relatively narrow QRS, 125. Once you do RV pacing, it goes up to 180. Okay. Now, but for these patients, what is different is that the ejection fraction was 4%, goes to 34%. So it develops heart failure with an NYHA class of 2.8. Now, in the past, what we would do is that we would upgrade them to a CRT. But now you can also choose to just replace their RV lead and give them a left bundle or His bundle lead, and the QRS will narrow, even narrower than before. Then the ejection fraction will improve. Okay, and this, in many ways, to me, this reversal of pacing-induced heart failure is a good evidence to me that physiological pacing is actually good for heart function. Now, people would say, well, why don't we just do bivent pacing? Because bivent pacing, is good too, right? And let me show you this. So this is activation maps. This is done using an ECG vest. So essentially, you wear an ECG vest that contains 256 electrodes, and you can see the entire ventricular activation. So the first panel here is people with left bundle branch block. You can see the RV activation is quite good. So somewhere here. And then the left ventricle is late, very late. Okay, so starts in RV, left ventricle is late. Now, if you do bivent pacing, you pace the RV and LV at the same time, it's better. Okay, so somewhere up here, right? So what you have is that LV and RV starts at the same time, and then the rest of the ventricles get activated. This is the His bundle pacing with correction that I showed you earlier. You can see the entire left ventricle is activated within one color zone. So it is activated very, very quickly. Now, and as a result of this, what you see is that His bundle pacing to correct left bundle branch block results in an increase in blood pressure. The LV activation time is also greatly reduced. QRS duration is much narrower, up to minus 35 milliseconds compared to BiV pacing. We also know that bivent pacing has some issues, mainly that it benefits predominantly patients with left bundle branch block and not patients with non-left bundle branch block. This is from the Medis CRT study. And you can see that in the left bundle branch patient, this is probability of death. CRT group does better than the ICD group. Okay, so this is the CRTD versus ICD study. But you can see in the non-left bundle pattern, in fact, there's a suggestion that the CRT patients do worse when you give them CRT compared to just giving them a single chamber ICD and not pacing them. Okay, and so there's a suggestion that why it either doesn't work, or there's even a suggestion once you adjust the analysis that CRT may be harmful in patients with non-left bundle patterns. So this was the seminal paper about 4 years ago that actually made everyone decide to start to practice some conduction system pacing. And this was from a very large registry. They compared patients who had right ventricular pacing, which is the orange line, and they looked at patients with His bundle pacing, which is the blue line. And you can see that when they used an endpoint of death, heart failure, hospitalization, or upgrade to bivent, this was more likely to happen if you had an RV pacemaker, RV pacing lead. Difference was biggest in patients who required ventricular pacing, so V pacing of more than 20%. Okay, And you had this reduction by 35%. This is our own data. So we've been doing conduction system pacing at NUH and as well as in the private sector for a while now, and we have almost identical result. So conduction system pacing at the top, RV pacing at the bottom, and we use the same endpoint, heart failure hospitalization, bivent pace, need to upgrade to bivent pacing, or all-cause mortality. And again, you see the same 60.61, so 39% reduction in heart failure hospitalization and death just by moving the position of your RV. And remember, this happens largely in patients with normal ejection fraction receiving pacemakers. So these are not heart failure patients. These are actually patients who you just put a pacemaker in for bradycardia. And this is some of our unpublished data where the paper is under review at the moment with circulation. We also know that when you do His bundle pacing, patients are less likely to develop AF, probably because you cause less heart failure. And so if you look at this study here, again, another registry, the percentage of patients who develop AF with right ventricular pacing is 41% versus 21% with His bundle pacing. Now, but His bundle pacing is not perfect. And so a lot of us are from doing His bundle pacing. So this is the Dr. Ellenbogen's registry. So success rate was very high to start, 93%, but when they followed up the patient, they realized the threshold was gradually rising. So these numbers here show the mean His bundle capture threshold over a 4-year period. And in fact, during follow-up, 24% of patients had a threshold more than 5, 17% of patients have loss of His bundle capture. And there was an 11% need for lead revision in their experience. And so really not ideal, okay? And this would, again, put a lot of people off starting. We also had this issue. This was from our experience. There's a learning curve to trying to do His bundle pacing. So the procedural time, fluoroscopic time, follow-up threshold only starts to get better after you've done about 30 cases. So clearly the learning curve is not short, even for operators who are experienced in pacing. So what do we do next? Because His bundle pacing seems to give us heart failure benefits, but then threshold keep going up. So from an EP point of view, it's not ideal. Now, for a few cases, we used the NAVEX system to have a look, and we figured out that basically the area you need to hit to get His bundle pacing is quite small. It's about 2 square centimeters. Whereas actually, if you were to target the left bundle, the area is much bigger. It's almost double, okay? And so the movement has now moved from His bundle pacing towards left bundle branch pacing, because the target is much bigger, the thresholds are much better, and the success rate is also very, very good, if not better. And technically, it's much, much easier to do, okay? Now, these two are still considered physiological pacing, but it's just that you're moving the insertion point of the lead a little bit down from the His bundle down to the proximal left bundle. So again, this is some of our data. We looked at our His bundle cases, and our left bundle cases, and we can see that the left bundle cases are in red. You can see that the threshold is much lower. The lead impedance is higher. This is good. You use less battery when the lead impedance is high. The R wave amplitude is bigger compared to His bundle leads, and the QRS duration is the same. Okay, so technically speaking, left bundle pacing is a better way of doing it. When we look at mortality, it seems like left bundle is better, but the difference is not statistically significant. And so this is, but certainly encouraging that left bundle doesn't do anything worse than His bundle pacing. And again, this paper is under review. So what about for our sicker patients with heart failure who need CRT? Well, so again, it's largely registry data at the moment. This is from a multi-center registry of 300 plus patients who need CRT. You can see that they recruited a large percentage of non-left bundle patients, 46%. Success rate was high, 85%. So it does tell you that, this cannot replace bivent pacing completely. because at times you're going to have to do bivalve pacing because 15% of cases is not successful doing this, right? But essentially what they did was that they inserted the lead to the proximal left bundle to provide left bundle pacing to correct for the left bundle branch block or the right bundle branch block. Threshold is very good, 0.6, R rate is 10, and the echo response is good, 72 and 73% in left bundle and non-left bundle, right? Remember I showed you the slide earlier, bivalve pacing doesn't really work very well for non-left bundle. Well, when you do CRT this way, it seems to work. So if you look at the smaller graphs here, you can see that there's a QRS duration reduction in the left bundle, that you also see that with the non-left bundle. But more encouragingly, the ejection fraction rises for both left bundle and non-left bundle. The heart gets smaller and the NYHA class improves. So for the non-left bundle patients, I think this is certainly much, much better than doing conventional bivalve pacing. So you may ask, I keep showing you registry data, where's the randomized control trial? They have started, but the ones that are published are few. So this is one of them. This is called the HIS alternative. They basically took 50 patients with left bundle and they randomized them to bivalve pacing the conventional way or HIS bundle CRT. And so again, they had a 72% success rate. So 28% of patients had to cross over to bivalve pacing. And I show you here, basically in both groups, the ejection fraction improved, the QRS duration went down, and the end systolic volume in both groups also went down, okay? On an intention to treat, which is how you're supposed to analyze this data, there's no difference between the bivalve group and the HIS CRT group. But per protocol analysis, remember, because there's a crossover, right? Some of the HIS bundle was unsuccessful, went over to bivalve pacing. If you look at it on a on treatment analysis, then the HIS CRT did better than bivalve pacing for left bundle branch heart failure. Okay, so this is a small study, but nonetheless, again, very encouraging that what we are doing seems to be improvement on what we used to do. And so this is my journey with conduction system pacing. We did the first case about 3 years ago now, and we decided that once we got past the learning curve, we would just do conduction system pacing. So we've done more than 500 now, and we've spread the practice to every hospital in Singapore. So over the last 4 years, 95% of our bivalve systems use either HIS bundle pacing or left bundle pacing strategy as the default rather than using bivalve. So to summarize, I think stimulating the conduction system is really the best way and safest way to pace the heart. I think almost all patients will benefit from this. And for us, the conduction system pacing is the default choice for our pacemakers and ICDs. And the randomized trials are now ongoing, and the guidelines, I think, will increase the level of recommendations for conduction system pacing in the next 2 years. And so with that, I thank you very much for the invitation to talk to everyone this morning. Are you on mute, Dr. Sutandar?
Thank you very much, Dr. Pipin, for your excellent presentation. To remind us that now the electrophysiology is much advanced in technology, so we should try to see the new paradigm for the HIS bundle pacing compared to the conventional RV pacing or the biventricular pacing. Oke, terima kasih Dr. Pipin presentasinya. Terima kasih juga Dr. Antono untuk presentasinya. Mungkin saya akan sedikit mereview hasil dari presentasi kita hari ini. Buat teman-teman yang punya pertanyaan boleh cantumkan di kolom chat sambil saya akan review apa saja yang sudah kita bicarakan pada pagi hari ini. Pagi ini Dr. Antono sudah membawakan sebuah kasus yang menarik mengenai ARVC, arrhythmogenic right ventricular cardiomyopathy, di mana kita harus mulai lebih aware, lebih teliti dalam membaca EKG, di mana di resting EKG di mana ada inverted di V1 sampai V4 sudah harus memberikan suatu awareness buat kita. Kemudian pasiennya datang dengan keluhan henti jantung dengan ventricular tachycardia dan bisa dilihat dari EKG-nya juga, dan kita lakukan DC shock, pasiennya recover, kemudian kita rule out untuk ACS dan koronernya normal. Dari hasil echo bagi kita para cardiologist mungkin harus lebih aware juga, lebih memperhatikan right ventricle. Selama ini kita banyak fokus di left ventricle, ternyata pada pasien-pasien seperti ini kita juga harus memperhatikan right ventricle-nya, di mana kita bisa melihat ada kelainan-kelainan yang bisa ditemukan di right ventricle-nya. Kemudian IPIS tadi mengkonfirmasi dan akhirnya pasien sebenarnya disarankan untuk pasang ICD, tapi sampai saat ini masih belum memutuskan. Kemudian pada presentasi kedua, Dokter Pipin juga sudah menjelaskan mengenai bagaimana seharusnya pada selama ini kita menggunakan pacing yang konvensional, tapi padahal kita memiliki sistem konduksi yang sangat luar biasa yang alami yang seharusnya bisa kita manfaatkan juga. Dan penelitian-penelitian terkini mulai menyarankan untuk beralih ke conduction system pacing, ke His bundle pacing. Dari hasil-hasilnya juga cukup menggembirakan, sehingga untuk kedepannya bisa dipertimbangkan sebagai terapi pilihan pada pasien-pasien dengan bradykardia atau gangguan sistem konduksi jantung. Oke.
Mungkin saya tambahin komentar sedikit ya. I think Dr. Pipin, after doing pacing, sometimes I really feel bad about having put in RV leads, you know. I mean, it's not just about the RV, the EF declining, and about 10% of our patient at least getting into left ventricular dysfunction. But we also have cases where they end up with severe TR. And I just have one who's being admitted with severe TR, which before had the normal RV size. And for the last, I think about the last 1 year, she was missed on follow-up because of COVID. But she was admitted to another hospital with recurrent heart failure, and it seems more like right ventricular failure, even progressing until liver dysfunction, enlarged liver, and now is having liver cirrhosis, or probably cardiac liver cirrhosis. Well, she also has diabetic, so it's very hard to exclude whether it's diabetic cirrhosis or whether it's our RV lead. But I really feel bad about putting the RV lead in, causing wide open TR and dilated the RV. So I think that's one problem. Now, in the past, we had this pacing system from Medtronic, and we had one case where we did several cases, but we only were able to get a His bundle pacing in some of the cases, and normally just a normal heart. And as you said, the threshold keep going up. We initially had the threshold of 1 fall. I'm seeing the patient 3 years later, and the threshold is now 2.75. And now I have to tell the patient, you know, on your next replacement, you know, we may need to do something else. That's one problem. And then, but I think the Medtronic was good for a normal heart and was very bad for a big heart. But I think the newer system from St. Jude, or which is now, it's not St. Jude anymore. I think it's now Abbott pacemakers. Seems to be more friendly. They have this sheet, delivery sheet that you can shape, and you put it in, you slit the sheet. So I'm very keen to start that system. The system has just been introduced in Indonesia, but I'm looking actually forward to trying this this system. One question that I have for you, what does the patient pay if you end up 15% end up not having a good LBBP pacing? Do you still end up putting the lead somewhere there, or do you really
Yeah, so it depends. If it is like a normal pacemaker patient, and let's say we try very hard and the left bundle, we cannot capture the left bundle, but we can capture good threshold on the septum, then we just leave it at the septum. It's like septal pacing. We don't the lead. If it is for a CRT patient, let's say we cannot correct the QRS and the patient has left bundle branch block, then we will abandon the left bundle system and we will then do a conventional CRT. So LV lead and RV lead, like how we always do it, right? So for CRT, we want to make the QRS as narrow as possible. That is the objective. And so whatever can achieve that, we use that as objective.
Yeah, any questions from the floor? Maybe Dr. Firman, maybe if there's any question to the floor, any question addressed to Dr. Pipin?
Ya, buat teman-teman, apabila ada pertanyaan boleh di kolom chat atau mau bertanya langsung juga boleh untuk ke Dr. Antono ataupun ke Dr. Pipin. Okay.
Atau semua terlalu shy, you can email me. My email is on the. I put my email in the chat room. And drop me an email.
Dr. Pipin, if you want to share about your group, I know you're working together with Edgar Tay and with some other people.
Yeah.
So you want to share promote your group a little bit, so maybe then we can have a closer cooperation between the two.
Yeah. No, nothing to promote lah. So I mean, we are a cardiology group. There's 8 of us. So there are 2 electrophysiologists, myself and Dr. Jeremy Chow. Then we have 2 heart failure physicians, and then we have 3 interventionists and 1 imaging person. So very similar to y'all. The 3 of us were from NUH. So there's Dr. Edgar Tay, myself, and Dr. Chan Wan Sien. So 3 of us are from NUH. 2 of them are from Heart Center, and 3 of them are from Changi. So I'm the newest joiner to the group. The group has been around for more than 10 years already. So actually, me and Edgar are the new joinees lah. And we are based out at all the Parkway hospitals. So we have a clinic in all the Parkway hospitals. But different people spend different time in different areas. So very happy to have the opportunity to speak to everyone. Come and visit us in Singapore if you're free. And so we can collaborate more in the future.
The other doctor is Dr. who? From NUH, is it Dr. Xian?
Dr. Chan Wan Sien. I think she wasn't there. Maybe she was a registrar when you were at NUH.
Oh, I know. She's a female doctor. She did hypertrophic cardiomyopathy, right?
Yeah.
Oh yeah. She was still your registrar. Yeah.
Registrar, right?
I remember, but of course you guys have surpassed me lah in.
No.
Okay.
Yeah, and then the Edgar and myself. So 3 out of 8 of us are from NUH.
Actually, I was we have a case that we actually want to involve Edgar.
Yeah.
Okay, it's we just discharged the patient for a TAFI.
Yeah.
Now it's an 86 or 88-year-old had a bioprosthetic implanted about 12 years ago.
Yeah.
And comes in with heart failure.
Yeah.
But also has a creatinine of about 3.2.
Yeah.
So we just did the CT scan to see whether we have good access and to take a look at the aortic valve.
Yeah.
The patient looks feasible from a vascular standpoint for a TAFI.
Yeah.
So we're just waiting for after the CT scan, the creatinine went up lah.
Yeah.
To 3.8. So we were telling the patients, we'll wait a little bit for your creatinine to come down.
Yeah.
And I've asked Medtronic to contact Dr. Edgar Tay.
Okay.
Yeah, I still remember Edgar also.
Yeah.
Yeah. So Yeah. You actually joined after I left, I guess. After.
Yes, I know. Yeah, I was following in your footsteps.
Yeah. Well, you guys certainly did a good job, lah. I'm very proud of the team there at NUH. I mean, Sweet Chong used also to be my my registrar. I remember him. Yeah, and then
You're the founding father of electrophysiology at NUH.
the oldest and the most writer. Me and Ang King Xiang actually. Ang King Xiang was also part of the team.
Yeah.
So, yeah, but yeah, maybe tell Edgar Tay that we have a possible case for him in store, and I'll get the Medtronic guys to contact him.
Yeah.
Yeah, and either I'll send the patient over there if they want to have it done over there.
Yeah.
But his input on the case would certainly be very helpful.
Yeah. Of course, happy to help.
Yeah. Okay. So, any questions from the floor? Maybe Dr. Fairman, if there's any questions from the floor. Otherwise, we'll close the meeting. And our greatest appreciation for Dr. Pipin for joining us. Maybe if you can tell your team if they are interested in having maybe a meeting every 3 months or something with our team where we can exchange cases and you guys can promote the latest advances in technology that you have over there in Singapore.
No, we can certainly do that. We can talk about different things. Sometimes we can talk about heavy stuff. We're doing some stuff around pulmonary embolism now, cardio-oncology. So happy to, we can make this a regular thing.
Yeah. Maybe you can rotate with your staff, or we can set up a meeting maybe every. You know what? Because I also need my what's the thing called, the thing that you need in Singapore 4 times a year, the
PRL.
Yeah, PRL. I haven't done my PRL this year, so.
Oh, okay.
So if you can guys fit me into your PRL, I can sign the PRL, and I get my 4 PRLs for this year.
Yeah. Sure.
So maybe this one, I just wonder whether your team can put it in as PRL or.
No, it's not that. You need some kind of registration. Let me find out how it works. So normally, the pathway is the one that puts the organizers put it in. So
yeah, we'll ask the Parkway people to put it in as PRL.
We'll see whether they can manage something to do like that.
Maybe you can ask your Parkway people also to put it in as, because I'm doing the same thing with raffles actually. The last 5 years I've been, or 3 years I think, after when did they start with PRL? Yeah, I forgot lah. Maybe 4 years or
5 years ago, I think. Yeah.
I've been doing the PRLs for raffles.
Yeah.
So instead of doing it, maybe we can have some combined things.
Yeah, sure. No problem.
We'll ask your Parkway people to organize it.
Yeah.
So then we can, I can get credit for my Singapore license and for my Indonesian license at the same time.
Okay, sure. No problem.
Okay, thanks, Dr. Pipin. Dr. Firman, any questions from the floor?
Ya, oke. Kesempatan terakhir mungkin buat teman-teman yang masih ada pertanyaan, any question, boleh bicara langsung atau mau dari kolom chat, silahkan. Kalau memang nggak ada, mungkin kita tutup aja ya, Dok ya?
Ya.
Oke, ya.
Oke, terima kasih untuk Dr. Antono atas presentasinya. Thank you very much, Dr. Pipin, for your great presentation, for joining us today here and share your knowledge. Hari ini kita sudah belajar banyak tentang electrophysiology. Terima kasih atas partisipasinya buat teman-teman semua. Terima kasih untuk Dr. Cecilia Padang selaku Ketua ID Jakarta Barat yang membuka acara pagi ini. Kalau sudah tidak ada pertanyaan lagi, mungkin kita sudahi pertemuan kita hari ini. Mudah-mudahan apa yang kita dapatkan hari ini bisa bermanfaat untuk dalam praktek kita sehari-hari nanti.